All right, thanks, Tim. I'll get started. So I'm talking about femoral shaft fractures. And Tim, what are femoral shaft fractures? No, he guessed the whole presentation in the lift on the way here, so he's already covered this. So, how do I move the things? What are they? Femoral shaft fractures are high energy injuries that happen to the femur, surprisingly, and they're often associated with other life-threatening injuries. So I think that's really the crux. I made this presentation about what we might see if we're interns in emergency rooms. So that's kind of the idea what I was thinking. So here are lots of examples of different versions of femoral shaft fractures, and a lot of them we're kind of used to and common with, and there are some overlaps with what Emma was talking about this morning. You can see the green stick there. And also, when you have high energy injuries, the femoral shaft fractures are also associated with femoral neck fractures, but they are two different things, kind of obviously, but it's always good to remember. So who do they happen to? So they have a bimodal distribution, and that's really based on the causative force of the fracture. So earlier in life, young males typically tend to be affected, and that's because they are high impact injuries. So think motor vehicle accidents, pedestrian versus car, falls from great heights, or other classic young men misadventures. And then we've got our older patients who will turn up, and these are your pathological fractures. So falling from, a standing height. And if a fracture happens here, it's what we were talking about before, it's that kind of indicative for osteoporosis. So there had to be a pre-existing osteopenia for them to have this kind of injury, as it's really quite a strong bone otherwise. And in long distance runners, you can sometimes get stress fractures in the femur, but you probably won't see that too much because that's a lot of running to get that. So clinically, what we will most likely see is patients coming from high impact traumas. So the number one thing you need to think about first is resuscitation and advanced life support. So it will be nice and easy to, the ortho reg might be on the sidelines excited to come in and help, but more importantly, you need to make sure that their airways and everything is stabilized and they're hemodynamically stable. And it's hard to miss a femoral fracture when they do come. So typically the thigh will be really swollen, it'll be quite tense, they won't want to move it, and you'll have those signs of fracture, so that tenderness on the region and the shortening of the bone, or if it's an open one, you'll just see the bone sticking out. Again, it's like quite high impact pictures. It's important that when you do see it, when you're doing your secondary, secondary survey of the patient, that you note the neurovascular status and the findings of the leg, just so you can kind of see if things change throughout their presentation. But diagnosis is made clinically and using a non-chest x-ray, a leg x-ray as well. I don't think it's fully relevant for us, but I put it in just to keep in mind. So there is a way of classifying them, and it's based on the degree of comminution? I don't know how to say the word fully. But basically, comminution, does anyone know how to say it? Anyway, is when one big thing becomes lots of little parts, I have learned. So the last one is the example of that, lots of little parts, and that's the worst possible fracture, but you can also expect to see that if somebody's been hit by a car. But then you've got the other end, you've got where the bone is just kind of either separated, or it's a green stick fracture, or it's those other. And there are degrees within that kind of exist. I don't think we need to know this at our level, but this is how you classify them. So moving on to management, here are some cool x-ray pictures for you. The most important thing with management is that there are often concurrent pathologies present. So if somebody's been in a trauma, they're more likely to have things such as thoracic injuries, and importantly, if you do try and intervene too early surgically with femoral fractures, you can lead to acute respiratory distress syndrome in patients. So it's really careful to take a second and make sure they're okay. And similarly with if they've got a brain bleed or something going on, if you try and put them under to do operations on the femur, you can exacerbate the neurological injury. So taking a second, you make sure the patient's okay before you go to their leg. But otherwise, treatment involves immediately kind of stabilization, pain relief, and if it's an open fracture, manage it appropriately. You can also splint it and provide some traction to it. I read that it doesn't necessarily fully required for better outcomes, but something you can do, and especially if you're transporting patients over long distances. And surgery is the definitive treatment. So the gold standard is this intramedullary rod, and it has nails, and the anterograde nailing is most common, but you can also go retrograde as well, but that's for the orthos. But if you can't do that, you can also externally fixate, which I've got a picture coming up, and then eventually put the intramedullary nail in within a couple of weeks. So there are two options that they'll pick. And if it's a pediatrics patient and it's kind of like the green stick fracture and things like that, you can just put them in a cast. And I thought this was kind of a cute picture. Sorry to the child. Ooh, where's my... The mouse is gone. So on the left are the pictures to do with the intramedullary nail that goes through, and then on the other side we've got the external fixation. So they put those nails in to begin with, and then later go in and put the rod. There are different reasons to do both ways. Complications. So I think the most important for us to think of is blood loss. So in a closed femoral shaft fracture, patients can be expected to lose up to 1 to 1.5 litres of blood in that space, which is kind of why you'll have that really tense, big, swollen area. In contrast, a tibial fracture is only about half a litre to a litre, which is still a lot, but the femoral shaft fracture can be quite a lot of blood gone. And keep in mind, if somebody comes in with an open fracture, they probably lost a lot of blood on the way as well. These kind of fractures are also associated rarely, but importantly, with things such as fat emboli. So when they do break, you can get little emboli of fat going through the bloodstream. And so you really want to make sure if that mental status changes, or they start to show signs of PEs or things like that, really considering that that could be a cause, which can be confusing when you've got a really sick patient in front of you. And also, apparently quite commonly, you can get ipsilateral injuries of the knee. So make sure you check the other leg. It'll be easy just to fixate on one leg, but checking that both are present and okay will be important. And here's just a list of other complications that occur due to femoral shaft fractures. Different degrees of commonness, I guess. So the heterotopic ossification is when the bone repairs, but then bone starts to grow outside of where it normally would. And apparently it happens quite commonly, which is really interesting. Pudendal nerve injury can happen, which is usually due to the traction rather than the actual break itself. Femoral artery and nerve injury is actually quite rare, despite all that blood loss. It's because there's so many muscles protecting those structures, which thanks to our body for doing that. But it is something to keep in mind, so checking that neurovascular status. Malunion and misalignment or malalignment is pretty rare, but it's more likely to happen in a proximal fracture. And of course, you'll have things such as muscle weakness, infection, and pain because you've got big metal rods in your legs. So all in all, pretty uncommon fracture from a day-to-day terms of like what your regular patients, but if you've got high impact trauma patients early on, something to really keep in mind, and also something to keep in mind with your older patients coming in with NOFs, just checking that they've also, how the rest of their leg is going is important as well. And that's all done, nice and short. The mouse is gone, so I actually can't stop it.
You can see it on the screen.
Oh.